This is session 3 of the 8-part series, the cohort of incorporating 988 as part of California's crisis continuum of care. I'm your presenter for today, your host. My name is Sue Ann O'Brien. I'm currently with RI International in the Crisis Now Academy. I do stuff related to their training and consulting team. I have just spent the last 3 years at Behavioral Health Link in Atlanta, Georgia, where I was CEO of the agency that operates the Georgia Crisis and Access Line, which is the statewide hotline for all of Georgia. Unlike California, which has 12 988 centers, in Georgia, we had just one 988 center, and that was us. Steve is the program director of Buckelew programs. I am going to hand it over to Steve. Steve, thanks for volunteering to be with us here today and sharing a little bit about your program.
My name's Steve Diamond. I am the program director at Buckelew Programs, which is a community-based behavioral health organization in the North Bay area. A little bit about me before I jump into all this presentation about 988 and suicide prevention. I've been doing crisis work for almost 15 years now in a variety of different roles and different agencies. And that includes quite a few different levels of care and types of service. So that includes residential programs, non-public school programs, hospital diversion, crisis stabilization, as well as substance use and co-occurring focus, mental health focus, even a little bit of work with families with kids with disabilities, and now suicide prevention-based programming that we're doing here at Buckelew Programs. So before I get into my specific program, I'll talk a little bit about Buckelew as a whole. It's a large organization that provides a wide variety of programming and covers multiple counties as well. So Buckelew started with housing programs primarily in 1970, added quite a few programs throughout the early 2010s. So in 2011, Helen Vine, a kind of sobering and detox program, was added to Buckelew Programs. Family Service Agency was added in 2012, and that included the mental health outpatient counseling program, as well as the crisis call center or suicide prevention hotline. And currently we are serving quite a few counties, like I said, Marin County, Sonoma County, Napa County, and also Mendocino and Lake counties for the suicide prevention program. In each of these counties, we have a variety of services, and that includes quite a few that cover the continuum of care in a large way. So we have the housing programs is kind of where Buckelew Programs started. We now have expanded to, like I said, Helen Vine for the substance use treatment side. We have a crisis residential program, Casa Renee. We also have the In Response team, which is a really exciting new program, which is a version of mobile crisis, but it has a variety of different providers, all part of the same team that can respond to the crisis. And that includes EMTs, community system navigators. We also have clinicians, as well as a fire department presence as well. So it's kind of a multidisciplinary team that goes and responds to those calls. And then we have the mental health counseling, like I had already mentioned, and housing, of course, being our foundation. That comes with community employment services, as well as just being able to connect people to resources in each of the communities where those housing programs are located. So Buckelew does a whole bunch of things, but my focus, and the one that I oversee, is the suicide prevention program. So for the suicide prevention program, we are one of the 988 crisis call centers. So the calls that come in through Lifeline, through 988 calls, those come to us for those counties that I had talked about, Marin, Sonoma, Mendocino, and Lake. We also have our local crisis lines. So within those counties, there's a specific number for each of those counties where they can call and it will go straight to us. We also respond to the grief line. And we also, in addition to those things, we provide a couple other supports and services. So the Survivor of Suicide group meets twice a month, and that's something that has been done virtually. Prior to the pandemic, we were doing it in person. We're hoping that we can sort of come to a hybrid model or have some version of both those things being offered in person or virtual. but that was obviously a big shift that we all went through during the whole pandemic. So the Survivors of Suicide group is a great resource for people who have lost loved ones or very close friends to suicide. And they're able to engage with a community that has a level of understanding and shared experience to kind of maintain that connection. So that happens twice a month on Wednesday evenings. We also are very excited to be adding text and chat in summer of 2023. So we're going to be pursuing that in June and July. Should have it in place by the end of June. So starting July 1, we should have that up and running and ready to go. We're in the process of getting everything in place for that. So very exciting to have more access and more opportunity for people to connect with us. As far as the 988 crisis call center and suicide prevention as a whole, we really are a huge part of SAMHSA's priorities and goals for crisis services. So on the larger scale, if we zoom out for a second and look at the big picture across the nation, the main priorities that SAMHSA have really set forth for crisis services are having someone to call, having somebody to respond when it's necessary to have an in-person response, and having somewhere to go if somebody needs additional services after the crisis, having a place where they can access those services. So when we look at those three, kind of that three-pronged approach, someone to call, 988 is a huge, huge portion of that, and making sure people can quickly and easily access support when they're going through a crisis. I don't know if anyone out there has experienced a high level of crisis themselves, or even if you haven't, think about the most intense workout you've ever done in your entire life. And immediately at the end of that workout, someone starts lecturing you, right? You're not going to be able to hear a lot of what that person's saying because you're so overwhelmed and exhausted and stressed, right? Your body is stressed. So that's kind of similar to why we want to pursue 988, because it's easier to remember 3 digits than it is to remember 10. So when we think about the continuum of services that are out there, and there are tons of different programs, tons of different resources, and we look at what that is both for the community-based support. So when something's happening in the community, your neighbor, your friend, a community member, someone at a school, whatever it might be. The options include community groups, maybe some outpatient counseling that meets, say, once a week. If things are becoming more of a crisis in the community, then there could be the need for a mobile response or a mobile crisis team to go and support and assess the situation. And certainly 911 is always a resource for people to use when it feels like there's an unsafe situation occurring. When we think about crisis programs and that additional support that might be necessary, we think about outpatient is certainly still a part of that. But then it gets to more residential based. So we talk about intensive outpatient, then we talk about partial hospitalization programming, which is usually a 2 to 4 week intensive residential type service. Residential programming, crisis residential, so that could be even shorter in duration of time. There's certainly crisis stabilization, where that could be a 23-hour stay at a particular facility or a particular program to prevent someone from needing to be hospitalized. And then we certainly have hospitalization when it's necessary for someone to have their medication checked out, maybe stabilize a little bit, and then feel safer to join the community afterwards. And the hospital diversion, like I had talked about, is kind of that 2 to 4 week sort of residential intensive programming. And those are offered in some counties, many counties, but not every county. So these are just some examples of services that could be available to respond to crisis. The need for Lifeline and 988, when we look at these different levels of care and these different services, there's a whole bunch that could be provided, but first somebody needs to be able to access those services, right? And oftentimes when people are in crisis, it's hard to really think through, well, I'm experiencing a crisis, but what do I truly need? Is it residential? Is it sobering or detox? Is it something more medication related or a medical provider? It's hard to really identify that when you're in the middle of a crisis. So instead of needing to remember all of these things and hopefully have some phone numbers saved in a phone, if you even are able to have a phone on you, um, hopefully having the access, the resources that you need to get yourself physically from point A to point B. In a lot of cases, people don't have access to those things, so they may not even be able to navigate that. Then additionally, to have a variety of different options and not quite know where to start. If people get really overwhelmed and really confused and the crisis is becoming too much, 988 is an easier thing to remember. It is far easier to think, there's a crisis happening. I don't know if it needs law enforcement response, but I do need some type of response. Where do I go? You can call 988. It's easier to remember. It's a good starting point, and it can at least move in the direction of getting access to resources and services that someone might need. So we also know that mental health is a huge growing concern around the country. We know that crises are increasing. There are high rates of suicide, self-harm, hospitalization, incarceration. There's trouble with access. We know that there are a lot of places to go, but we also know there are a lot of limitations. It may be the program is full, there may be short staffing, there may be eligibility criteria at various places, and that may or may not work for the person who's in crisis. And the crisis response that we've had historically is not necessarily meeting the needs of the individuals or the community. We know that there's a greater need than the amount of resources that are available. So that's an area that we're really trying to work on. A little bit about the history. I know that a lot of folks already know a good chunk of this, so I will just briefly touch on it. When we think about 988 and suicide prevention, it wasn't until 2001 when there was the suicide prevention hotline that was made available the way we know it today. So when we think about the whole history of mental health services and crisis services, it's pretty new. 2001 is not so very long ago in the grand scheme of mental health services that we've even had a suicide prevention hotline. Then there were adjustments made to try and meet the needs of the community throughout the last, 20 some years, to try and meet the needs of, for example, veterans, LGBTQIA plus community. There have been just a variety of different things that were put in place to try and meet the needs of the community. And then more recently, it was the decision to launch 988 so that people would have increased access and again, be able to quickly and easily get in touch with some level of support when they kind of weren't sure where to start, but clearly were in need of support. So that wasn't until about less than a year ago. Almost a year ago, we're coming up on our 1-year anniversary, which is very exciting. But we, again, it's a newer service and it's a very valuable service, but it is new and we're working out any of the kinks, any of the challenges that we're facing, right? But the goal is always to increase access and support for the community. So like I was just talking about, we want to increase access, we want to provide support and reduce the risk of hospitalization and incarceration. And we also want to make sure the right resources go to the right places. We don't want to have 5 or 6 different types of resources and types of support showing up when really we know only one of those may be the appropriate one to meet the needs of what's happening in the crisis. That would reduce the stress on our whole system of care so that people aren't being pulled in a bunch of different directions and they're truly responding to the situation that they should be responding to that meets the needs of that individual or community. So this is another one that I'll touch on just briefly because I think a lot of people are aware of this, but just in case you're not, when you contact 988 or call the Lifeline, you will have a couple of options. And there are now more options than are shown on this slide, but there are at least 3 or 4. I think that's going to be expanding even further to get more direct access to what you're looking for. So it could be the general suicide prevention support type of line. It could also be something specifically for veterans, specifically based on language needs, if it's for Spanish speaking, and LGBTQIA plus community, is another option. So you'll have an option of press this number, that number, or the other number to make sure you get access to the support that you're looking for. And then there are a lot of kind of misunderstandings and myths out there. When you call 988, as far as what you can expect, the counselors who are responding to those calls, whether that's phone call, text, or chat, there's a lot of training that's involved. So there's at least 40 hours of training. That includes all kinds of interventions, safety planning, risk assessment, connecting with a variety of different types of communities and strategies and best practices for that. There's also just general understanding of how to engage somebody in a supportive way. The whole point of calling a crisis call center is that you're getting some level of professional support. Oftentimes, it's also people who have personal experience in addition to their professional experience, but you're not calling to, contact your best friend who's gonna give you their personal opinions, right? You're contacting somebody to get a different type of support that may be a little more, non-judgmental, unbiased, something that can be somebody who's professionally trained to actually engage in those discussions and provide that support. So there are a lot of different therapeutic techniques, intervention techniques, and supportive tools that people are trained on, so that when somebody is making that call, they're getting the best quality care that is possible for us to provide. And we're always expanding and building upon that as well. It's not something that we just say, hey, we did it and we're going to stop talking about it. We're always constantly growing in that area to make sure that we can meet the needs of the people who are calling. But as far as the myths, there are still a lot of kind of myths and misunderstandings out there. 988 is not affiliated with 911. I always want to make sure that is clear. Yes, they're 3-digit numbers. Yes, they both start with 9. That does not mean that they are connected in any way. If somebody needs 911, we can certainly connect them to making that call, but we are not directly connected and affiliated with 911. So I want to make sure everyone is clear on that. 988 also does not track callers. We do not have geolocation. We do not know exactly where somebody is physically located. If someone calls us, we're not going to immediately be sending people to bust down the door to go and meet somebody and intervene. That is not what 988 is here for. That is not how we operate. So our goal is always to support the person who's contacting us, make sure they're in a safe situation, and help them, reduce the level of risk and be in a as safe as possible type situation that they can be in. So we don't track callers. That is not what we do. 988 also provides people with increased access for suicide prevention or for other referrals. So if someone calls and they are needing suicide prevention services, we will continue to engage in that and support that person. If somebody calls because they were looking for a mental health resource that is not suicide prevention, we can help provide some referrals and some resources that the person can then go and access and engage with. So that's really what it's here for, right? And then 988 is here truly to help you kind of get what's needed. So if that is mobile crisis, we can certainly help with that. If that is law enforcement or an ambulance, we can certainly help with those things. But we can also help with things like, I don't know how to get in touch with a therapist and I really need a therapist, that I can work with and meet with once a week. Great. Here's a resource. Here's a phone number you can call. Right? And we'd help people kind of get that process started. So it's a good way if you're not sure, but that mental health resources are needed and that someone is struggling or having a hard time, it's a good starting place. And it's about the prevention side of things. So we don't want to wait until it's already a massive crisis. If someone is feeling like things are moving in that direction, you can always call. And it's all about kind of the main point. It's a lot of complexity in this continuum of care. There's a lot of complexity and confusion when it comes to mental health in general or any sort of human services support. So we really want to keep it as clear as possible. The main point of why 988 is here and what we're trying to accomplish. We know people need support and they're not getting all the support that they truly need. We know that resources are limited. And as much as we would love to provide everything that everyone is needing, we know that's not always available. And we know that the system can be really difficult to navigate. It's hard to know where to start, especially if you've never experienced this type of crisis before and you're experiencing it for the first time, or you have a family member or a loved one who's experiencing it for the first time. It is not easy to just automatically know how to navigate the system to get what you're looking for. So that's why 988 is here. That's the main point, to help people have their needs met, to help people access resources as quickly and easily as possible, and to make sure that when someone doesn't know where to go, doesn't know how to start that process, that there's at least somewhere that they can call, because we are that someone to call part of the SAMHSA model and the SAMHSA priorities. So those are kind of the main pieces, the big overview that I wanted to share. So we're very lucky that we have good relationships with a variety of other providers in the community. We work very closely with the county, with mobile crisis, with law enforcement, with case managers and other behavioral health providers. So we're able to connect very well with them, and that makes it easier for us to do the referrals and connect people to the resources. We also do have community outreach coordinators and a development department that do a great job of making sure that the community members, just the average person who's in any of these counties, is aware of these resources and aware of these services. And a big part of that is connecting with schools and connecting with other community-based organizations and even medical providers, and making sure they have cards, brochures, wristbands, anything that shows suicide prevention 988, contact us, right? And people can know, oh, Buckelew programs, that is the place to go to if I need suicide prevention or mental health services or whatever it might be. So we really, we have a great team. I'm a big fan of our development team and our community outreach team. Really getting out there to a variety of different places to share that information. And we're trying to really meet the needs of the community, like I had said. So as we track data and we look at what's the highest level risk, we track that as far as, age range, race, ethnicity, gender, and we kind of look at all these things and say, okay, so with the information we have, where are some places that we really need to get this information out to? So for us, older adults have been one population that we've started looking more closely at and saying, okay, so we have to go to places where we can connect more with this community and make sure they have these resources. And we do the same thing with schools and just in different communities, depending on where the needs are.
How about with 911? Can you talk a little bit about your call agents and how they connect or work with 911 when you do an assessment and you determine that this caller, it's a life-threatening emergency?
For 988, we get over 700 calls a month, between 700 and 750 988 or lifeline calls. We also get, just with that and our grief line and our local hotlines, we get over 1,500 calls a month for our hotline as a whole. So of all of these calls in any given month, there's only really a handful of calls, like maybe 5 or 6, that usually require either law enforcement or an ambulance or something of that nature to respond. So overall, I think that speaks well to what our hotline counselors are able to accomplish in a call as far as safety planning and risk assessment and de-escalation and crisis intervention through those verbal interventions. I think there are situations where we get a call of a suicide in progress where we have to have an in-person response right away. In those circumstances, we are able to contact 911, relay whatever critical information is necessary. If the person has told us where they're located and, said, here's where I am, here's what's happening, then we're able to relay that information to get that in-person response. We are also able to physically connect the calls so we can kind of conference call in 911 as needed. More often than not, we also, again, I'll say we've been lucky in this sense that there are times that our callers call and it is that high level of crisis, but during the course of the conversation, they are actually able to make that call independently on their own. And they, we make sure that they have the ability to call 911. And we talk about what that'll look like and we sort of walk them through it, and then they're able to make that call themselves.
The next area for discussion, and you just started touching on this a little bit, Steve, in terms of the KPI, sounds like a really low percentage of those 700 or 800 calls every month actually require a higher level of response or law enforcement engagement, which is a real testament to the skill of your callers and really being able to. The primary difference, of course, between 988 and 911 is that calling 988 is an intervention. It is not just a triage to somewhere else. It's an intervention in and of itself. So the numbers you just described really show that that intervention is effective and impactful to the people that are calling your program. Can you talk a little bit about what are those top KPIs that Buckelew is tracking and measuring every month, and how you as a management team kind of take a look at those numbers, or just your performance management process?
So there's a whole bunch of data that we would like to collect. Also, the goal, like we had talked about, is always going to be focused on the safety of the caller, priority one, always. So we'd love to have all the demographic information. We'd love to have all the different categories and, exact community stuff and all the circumstances and all of the pieces around it. The reality is we know we don't always get that information because there are other priorities around intervening and maintaining safety, but we do try and gather information around age, race, gender, where they're calling from. So that's both the city and the county. And we take a look at what those trends are, and we try and notice if there's an increase in any particular community versus the others, right? And we try and notice if there is quite an increase in, let's say, high school age or transitional age or older adult. We try and really notice, okay, there's a big increase in this community, this population. We now need to devote a little more of our resources to providing support for that community or marketing things a little bit differently so that they feel more comfortable contacting us and getting that support, or even trying to encourage more community support for that group. More clinicians, more community groups, right? More drop-in availability for clubs, groups, any type of engagement that could be useful. As far as the KPIs, we also are very, very interested in tracking how quickly we're able to get to a phone call. So if there are a bunch of calls coming in at one time, how quickly are we able to respond to each of them, and how long are people waiting on the line when they're calling? We don't want that to be a very long time that people are waiting for someone to respond. So we keep a very close eye on that number. And then there are times, if we're in the middle of a very intense call, or even a couple of very intense calls, and somebody's calling and we're not able to get to that, we are lucky that with the 988 system, people are able to have the call roll over to a backup center. So if it's not able to be responded to right away, or we're not able to get to that call, there is someone who will be able to get to that call. So the person's not going to be waiting forever and ever on the phone. So we're kind of really focused on those really high priority ones. And, I'm very happy to say that our response rate, our answer rate for calls is less than 20 seconds, which I know can also feel like a long time. 20 seconds can feel like a long time when you're on that call. But in the grand scheme of what it could be, under 20 seconds is certainly not a bad place to start. And we always want that to be faster and faster, right? That we can get to those calls. So we look at that information. We have a whole bunch of other data as well. And we kind of look at each of those to notice the trends and see where we need to adjust our operations. We also can look at our staffing model if we're getting more calls during a particular time of day or time of night then we can adjust our staffing to have more people working at that particular time of day or night. So we really try and use the data more for that to maximize our performance on the hotline and make sure our operations are meeting the needs. And that's a huge part of what we do with it.
The top KPIs, for those of you on the call that might also be part of Lifeline's 988 centers, there are a set list of reportable options, requirements to the Lifeline that include exactly what Steve just talked about. So the average speed of answer, the length of the call resolution or status disposition, and just tracking those key performance indicators, those measures of efficiency every month. And it sounds like Steve's team's doing a great job of seeing where they might even have some improvements. While you were talking, I did think, I was reminded that I wanted to ask you about the makeup of your staff. Are they master's level licensed individuals? Is it a combination of licensed and bachelor's level? And what's a little bit about your internal process if a staff needs additional clinical support in the middle of a call?
Yeah, so definitely combination. We have people with a lot of different experiences. As somebody who's gone through different levels of school, training and knowledge, there are some things that are taught very well, and there are some things that are not taught as effectively. And I think there are some people who have, whether it's personal experience or other types of work experience, where that actually may speak even better to a crisis line than a licensed clinician who hasn't done crisis work, for example. So we have a combination, and we try and look at everyone's skill set and how that would fit with the program that we're providing, more so than looking at like educational requirements or educational background. We do have the training that we provide both for our direct hotline counselors as well as for people on our leadership team. There's some additional training that comes into that. So we make sure that our training covers any concerns that we may have in somebody's either education level or experience level. And we definitely take that into account when we're looking to hire, but really more so what we're looking for is people who can make the adjustments quickly in a call. So one of the big differences in this type of crisis work versus some other types of programs and some other parts of that continuum of care is things can change very, very quickly. So if someone, it could sound like somebody's doing okay in a call, and then all of a sudden it seems like things have changed drastically, and all of a sudden it feels like more of a crisis situation, and we might need to take those additional steps. So we really, prioritize people who are able to be flexible and make those adjustments and be able to do so while also maintaining that level of care and connection with the caller, and be able to also take care of themselves in that call too, and not get caught up in that crisis, and kind of maintain that neutrality to support the person effectively without being overwhelmed. And our team does debriefings, and we do, different supervision meetings and things like that to support our hotline counselors if they have had a difficult call, to make sure that they can sort of recover from that and bounce back from that, and not have that become so overwhelming that it's too much.
It would be great to hear, Steve, from you, any of successes, things you're really proud of, things you tested or tried and figured out that it worked, any innovations that you might be using.
There have been some innovations across the 988 group as a whole, and especially in 988 California. I have to acknowledge Didi Hirsch putting together some great online platforms that we can use for training. And that helps not just for initial training, but for refreshers when people need to revisit a particular topic. When you're operating a 24/7 hotline, it's hard to find exactly what day and time will work best to provide a training. So that is definitely a very helpful tool. So I thank Didi Hirsch for helping to put that together and get that in place. But I think we as a program have a couple things. One, a on-call system that we've put in place so that it's a rotation of the leadership team members in the program who take turns for about a week at a time being available 24/7 for consultation, debriefing, any sort of concerns that one of our hotline staff may have, that they have somebody they can reach out to talk to at any point in time. So throughout, even during the overnight shift, that there's someone they can reach out to. I think that's really important for a couple reasons. And I think it's great to have a variety of people on the leadership team be that person, because it creates, I think, a little more cohesion in the team where people can feel comfortable and not feel like it's just a name and an email, like they can actually reach out and call someone and talk to them. And then I also think just the way we do supervision. So you had mentioned clinical earlier, and I know there are some places where like clinicians are kind of the primary workforce for the hotline. And when that's the case, there may be needs for a certain standard of 1 hour of individual supervision, 2 hours of group supervision, things like that from Board of Behavioral Services or Behavioral Sciences, and different organizations that kind of require and mandate a certain level of supervision. We sort of believe that we should have a similar thing happening for any of our hotline staff. So whether that, clinical or non-clinical, whoever is working on the hotline, we want to be providing that hour of supervision once a week as best we can. And we want to be providing some level of group supervision or meeting that's happening regularly as well, so that people have a chance to discuss trends on the hotline, difficult calls, debrief any situations that may have come up, and really make sure they have the support they need, because that's our team that's on the front lines of this and providing that direct service to the callers. So if we're not doing our best to support them, then that's going to translate into not as good interactions and not as good support on the hotline. So we want to really do our best to provide those layers of support. And I think that's a really nice thing that we've set up as far as that individual supervision that people are getting.
What are your barriers or things you're still kind of working on or trying to address, either just in general or related to since the implementation of 988?
Improvements that are being made with regards to cultural awareness and, reaching out to different, a variety of communities that really need the support but haven't historically gotten the support. I think we've made a very concentrated effort to try and move in that direction and acknowledge those things, and hire people that we feel will be able to connect with the community across the board, and have our team be representative of the people we're trying to support. We've made a really concentrated effort with that. I know all the other 988 call centers across California have also made a very concentrated effort. I think there's still a huge challenge there. This system of care, and as a whole, any sort of crisis service, behavioral health service, psychological service that's provided, has historically been not helpful and been very harmful in some cases to people of color, and a lot of communities. And that's something that doesn't go away overnight. And that's certainly something that doesn't go away just because we change a phone number, right? So that is an ongoing need. That's an ongoing challenge. And it's going to take time, and it's going to take a very concentrated, mindful effort. And it's going to take ongoing engagement, not just something that we can check off and say, hey, we paid attention to this, look at us, right? I mean, that's not the point. The point is we need to provide some real support that's going to connect with the people we're trying to connect with. And that's not going to come out of a book or out of a training. That's going to come with ongoing intentional efforts that really include listening to our community and hearing what's needed, and being willing to make the tough decisions and make the adjustments that are needed to do better. Because I am very, very well aware that people like me aren't all the people who are calling, right? There are a lot of people who are calling who don't look like me, and we need to be supporting everyone who's calling, not just the people who look like me in the North Bay, because that's not really doing justice to what we're trying to accomplish.
You make a really good point. And I think the other challenge to that you touched on earlier is just a reminder to everybody that 988 does not, at this time at least, have geolocation capabilities. That is still being discussed at SAMHSA, whether or not, and of course there's pros and cons to both. If we want 988 to be a life-saving hotline, we need to know where folks are. One of the challenges with 988 is that it's still set up just like the Lifeline was set up. And in fact, 988 is the Lifeline. When you call the 10-digit Lifeline number, it's just rolling over to 988. Yeah, replacement for the 10-digit Lifeline number. But not only does 988 not have geolocation, but it's still being driven by your area code. So in this day and age, of course, a lot of people are mobile. I moved from Phoenix to Atlanta, and I still have a cell phone with a 602 Phoenix area code. So if I'm in crisis, while I'm in Atlanta and I call 988, that call is going to be answered by the 988 center in the 602 area code, which is the Crisis Response Network in Phoenix, Arizona. And so that has limitations on getting me as a caller connected to those services in my community. And so this is another area I think will be the next hurdle for all of us that are operating 988 centers.
The main thing and the main purpose for 988 being access to resources. The people who know the best resources that someone can access in that local area is the call center who's in that local area. So yeah, if somebody calls and they're saying, I'm in New York, but my phone number, I grew up in Marin, so my phone number is Marin, we can provide de-escalation and some verbal support and some safety planning and things like that. But if they're saying, I need access to the local resource in New York, and here's what I'm looking for, we can look that up. And we do have quite a few resources. We have a whole book of resources, but that's going to take a heck of a lot more time than if it went straight to the New York local line, who could then say, oh yeah, it's called this, here's the number, here's what you can expect, here's how it looks. They would just have more detailed information on that, and that is a huge challenge that we face. So yeah, there's absolutely cost and benefit to everything, but in those high level of crisis calls, those really high risk ones, the goal of 988 was always meant to be quick and easy access to the appropriate resource that's needed. And the quicker you can get in touch with the local hotline, the more likely you can get quick access to local resources with wherever you're physically located, not just where your phone number's from.
There hasn't been any kind of national level research, but we do know in states that have conducted research on their states that have a statewide call center, like one number statewide or a handful of numbers statewide, like Arizona, Georgia, Colorado, all of them have found that having a 24/7 hotline greatly reduces the percentage of folks that are going to the emergency department, that are, if you can avoid calling 911 and instead call 988, there can be significant reductions in the amount of law enforcement time, just the cost savings to the system of care, to the community in general, just from diversion from law enforcement and high cost EDs. And I would just also throw out there for those of you that might not know, states do have the option through federal legislation, 988 legislation now, to impose a cell phone tax. All of us on our cell phone bill, you've seen your 911, your small 911 fee that all of us pay every month. That legislation, if your state decides to pursue that, you can, states can pass that legislation so that they can charge 25 cents, 33 cents, whatever they determine of a 988 fee. And those funds can go directly into funding The expansion, as Steve noted, call volumes continuing to increase. The centers need a lot more staff, and it's becoming very difficult to get those staff. It's competitive to hire right now, and it's even more competitive to hire really, really well qualified individuals. This is, as Steve noted, some pretty difficult work that takes a special individual to do. So there are funding opportunities out there, which is great. Historically, it was kind of cobbled together, some local funding, maybe some fundraising, county or state dollars, but not a lot of federal support. So we're seeing that shift as well with the advent of 988. So that's all great news.
And with the KPIs also, we do track risk level at the start of the call and sort of risk level at the end of the call. So we do have a question that we ask, how likely are you to kill yourself today or in the next 24 hours, right? And we kind of track that where someone is at the start of the call and then where they are at the end of the call. So we do have some data there as well to show that the risk level decreased or at least didn't increase during the course of the call. So that is helpful when we're trying to make those arguments and trying to really say, look, here's how effective this is. And we know that it's very effective. We know that it's very helpful. It just takes that extra, again, just connecting those dots. We need to draw that extra line to connect that dot and help people kind of realize the big picture.
We will wrap up for today. I want to thank Steve again for a really great presentation. It was a really pleasure to meet you and hear about Buckelew programs. Thanks for joining us today.